is quite exciting to see from the history that even during the Roman Empire, Greek physicians used to show interest in ACL. We know that ACL is a common injury and over 200,000 injury happens in USA. Reconstruction is still considered a gold standard. But we also know from the fact that it doesn't come without complication, with risk of infection, revision, dissatisfaction, anterior knee pain, quads atrophy, and osteoarthritis. Today our debate is why primary ACL repair and reconstruction, which both started together, one took popularity over other. If we look at the history, Mayo Robson performed the first primary ACL repair in 41-year-old minors. During the same time in 1970s, Haygroves published his work on ACL reconstruction. Later that year, Palmer popularized open primary ACL repair, and that became the most popular performed procedure in 1980s. But Fiagan and Curl were the first to note that deterioration of result at midterm follow-up in 1976. So why this paradigm shift happened? In early 1990s, several randomized controlled trials were performed showing superior result of reconstruction. Let's look at the evolution of primary ACL repair through the prism of modern day understanding. The turning point happened when Sherman in 1991 understood and re-looked at the result of primary ACL repair, and he divided ACL tear into 4 subgroups. Type 1, which is proximal tear less than 30% separation. Type 2, more than 30% separation. Type 3, mid-substance, and type 4 from the tibial sided avulsion. And he found that type 1 and type 2 tear have the best result. Through the literature in 1980s to 90, the results showed in mid-substance to be the worst and higher failure rate. But during the same time, other studies by Cooney, Janelin, and Ronest showed much better and satisfactory results in proximal tear. Janelin found that in 42 patient proximal tear at 5 to 7 year follow-up, 86% of patients were satisfied. So what were the factors that played a role in this paradigm shift from a repair toward reconstruction? During the early 80s and 90s, Google and Embase were not as much popularized and easy to use for orthopedic surgeons. The language barrier was another concern. Majority of the literature was written in a foreign language. Arthroscopic companies were focusing more on developing equipment to support reconstruction rather than repair. And as we know that the repair was done openly, it was not popular among surgeons. But before this, one should know that has ACL the potential to heal? The healing potential of ACL tissue has been read and studied by Sonnery, Cotat, and Murray. In their study, they took the samples and looked at the histological and cellular evaluation, and they found that the ruptured end of the ACL has got well-vascularized synovial tissue, numerous fibroblasts and myofibroblast and mechanoreceptor. Along with our histopathologist colleague, 20 damaged samples and 6 normal samples. We use CD34 immunohistochemical staining, which expresses cell surface marker, and we also identified fibroblast. We used hematoxylin and eosin staining, and when we compared the cellular characteristic in total of 52 biopsy samples between a healthy and torn, partial and complete ACL tear, we identified that in a torn ACL there was a significant higher values in synovial angiogenesis, ligament angiogenesis, and fibrocytes. But the most exciting part of the study was time-specific response, that the remnant angiogenic potential significantly decrease 1 year after the injury. So either you intervene early to preserve the stump or repair. Our study was published in the Knee Journal, and we also presented during the ICRS. So what's happening now that we are back to the future and primary ACL repair is becoming more popular? There are various options to do primary ACL repair: suture anchor repair, bridge enhance ACL repair, internal bracing, and dynamic intra-ligament stabilization. We do not have huge amount of literature so far, but we are seeing interest toward publishing more and more work on primary ACL repair in the last 2 years. My inspiration came from Gregor de Phillis, a dear friend who has published most of the work on primary ACL repair using suture anchor and internal brace. In his technique, he uses 2 swivel lock plus an internal brace to repair his primary ACL repair. Bridge Enhanced ACL repair was published by Murray and studied, in which you take a sponge of a scaffold attached to the torn end of the ACL, take a patient blood, infiltrate into it, and in the trial, which was done in 2016 of 10 selected patients, in 2019 the published result of 2 years showed similar outcome to ACL reconstruction. Internal brace was developed by Gordon McKay from Scotland, in which the concept of an internal brace is exactly like a seat belt. You repair the ACL, and like a seat belt, it will prevent the graft from rupturing. A 68 patient case series at 1 year follow-up showed 1% failure and 4% revision. Dynamic intra-ligament stabilization has been studied the most. The largest case series on humans, over 300 patients, has shown much higher failure rate at 5 years follow-up. The intra-ligament stabilization fixes on the proximal part with endo button and dynamic stabilizer onto the tibial side. But the issue is that you have to remove the screw 6 months following surgery. So the patient potentially needs to undergo 2 surgeries. When I developed my technique of primary ACL repair, my concern were drilling the tunnels, removal of hardware, ease of during surgery, and cost. So I decided to use a single anchor, focus mostly on type 1 and 2 tear, no tunnels, and easy to revise. And that was my approach. So my indication was type 1 and type 2 tear, age over 25, because I feel they do much better than a younger age. Clinical exam plus MRI scan, arthroscopic exam to proceed. Good tissue quality to hold the sutures, and in grade 2-3 cartilage damage and multi-ligament, we excluded our patient. So I will quickly take you through the procedure, how we do our primary ACL repair. MRI scan is showing proximal tear. And as you can see, rest of the ligament is still attached. With the help of arthroscope, I use 3-portal technique, anteromedial, anterolateral, and the central port. The central port is important not only for visualization but also for suture management. Examine the ACL tissue, and then basic instrumentation is used: suture cutter, suture passer, drill bit, drill guide, suture manipulator, and suture. I only use 2 suture. With the first suture, which is the locking stitch, you hold the tissue, and the running stitch is the second suture. It's very important to be very careful not to take the suture alongside the PCL, so you have to rotate your arm or use a probe to bring the loop or the Bunnell stitch more proximal as possible, close to the footprint. Once all sutures are done, with the help of the drill guide exactly at the position of the footprint, you drill and then use your anchor. I use relax anchor that can accommodate 4 ends of the suture. It's technically easy to use. And once all 4 ends of the sutures are Deployed, you insert the anchor into the area of the drill part of the anchor and then tension it so that there isn't any slack. And finally, you can insert the anchor up to the black dotted line. You remove the white end of the sutures and you do the tensioning effect to allow, if there is any minimum slack, to be removed. Once that is done, the anchor is removed. Nice and stable graft. We can feed it with the probe. As you can see, looks nice and stable. Cut the suture end, take the knee through range of movement. Perform microfracture to allow pleuropotential cell to fall onto the graft, and with the 3-portal technique, the ACL primary repair has been done. 24 months follow-up is showing nice position of the anchor with completely healed ACL tissue, and clinical examination is showing stable graft. We have done so far 52 patients, no failure, no revision at almost 2 years follow-up. We are following them with IKDC and Tegner score. MRI scan is done at 6 months, and we will be running our first randomized controlled trial by end of this year. You can also consider repairing type 4 tear, which I have done in quite a few cases with successful result, but if it is done acutely and in a very young age rather than chronic cases. So in conclusion, the way we preserve the nature, we should save the ACL. And thank you very much.